All right, welcome folks to the MMOA podcast brought to you by the Institute of Clinical Excellence. My name is Dr. Dustin Jones, physical therapist and faculty member with the Institute of Clinical Excellence. And I have Rashelle Hoffman with me, and we're going to have an awesome conversation about specialization because in the current state of affairs within the context of physical therapy, there's different options to try and level up your skills to serve a particular population. We're going to discuss kind of the pros and cons of each. While acknowledging like our own biases. I'm gonna start with mine, then Rachelle's gonna introduce herself, and so you give a little bit of background. But for the context of this conversation, I sat for my GCS. This was in, I believe, 2016, 2017. So it was doing home health, kind of out there on my own. Wanted to level up my skills, and in the current life situation, sitting for the exam was one that I decided to do. And so I sat for that exam, took it, continued to do home health afterwards, and saw a lot of cons that we're going to discuss with that particular path that really motivated me to start creating continuing education, to teaching a certification. And so if you're listening to this, we teach Con Ed. We teach a specialty certification in older adults. So I want to really acknowledge my bias in this conversation, but I do want to accurately portray the other avenues to get better what we do to better serve older adults. And knowing that the one that I provide is not the only one, it may not even be the best one for you in your situation. So acknowledging that. All right, so I'm going to have this conversation with Rashelle Hoffman. Rashelle, would you mind giving folks an idea of your professional background, because you have an incredible resume when I'm looking at your site here.
Oh, well, thank you, Dustin. And I really appreciate being invited to this conversation to kind of give my perspective on ways to pursue specialization. So for those of you that don't know me, I'm Rashelle Hoffman. I'm an assistant professor at Creighton University, and I pursued the path of residency education for my specialization. So I was a resident back at Creighton University, started residency in 2025, finished in 2026, sat for my specialization exam then in 2027. So I don't know, we might have been taking the exam the same year, Dustin.
That's wild. Where did you go to PT school? Were you at Creighton?
No, I actually went to the University of Nebraska Medical Center for physical therapy school. So just about 30 blocks from Creighton. So not too far. And really also my role, so currently at Creighton, I'm the director of the Geriatric Residency program. So now I'm advanced to the leadership on that side. And just to further expand kind of on my path. So after residency, I really was interested in the scholarship component that we'll talk more about that residency can offer for you. And so I went on to do more research after residency and pursued a PhD. Went and did some fellowship training out at the University of Colorado at the Anschutz Medical Campus, doing a lot of clinical trials with older adults, and then came back for my current faculty position here, where I do quite a bit of research with older adults and exercise, how I can maximize mobility and cognition. That's kind of my intro in a nutshell, and I'll let you kind of lead us with our discussion today, Dustin.
Yeah. So I think we're wanting to discuss, I think, three main avenues for specialization. And so we'll break down kind of the pros and cons of each, and kind of like when you may want to pursue that particular route, and when you may not, right? And I think there's certain instances where one is the best option or the worst. Like I think it really depends on the situation, but hopefully we can give a little bit of guidance here. So let's start with the PT program going into a geriatric residency. We'll discuss that. Then we'll discuss if you don't do the residency but still sit for your GCS. That was a route that I took, and then we can end with just in the continuing education realm of pursuing certification in that realm. So let's start with, for those that may not be aware, could you describe kind of the nuts and bolts of your geriatric residency program, of what does it tangibly look like when someone is accepted into that? What does their life look like for the next, X number of years?
Yeah, so I'll describe a bit of the requirements in order to be a credentialed program through ABTREAT.
Okay.
So that's our accrediting body. So the basic bones of what a residency program needs to have specifically for geriatrics is they have to have a minimum 1,500 hours of clinical practice over the residency program. There is variability in the length of residency programs that I'll say most of them are a year in length, but some of them are 15 months, 18 months. So there's some specifics there for the particular residency programs. And with that 1,500 hours, you have to have, so the numbers might get a little complex here. You have to have a minimum of 5% across 4 different areas. So the 4 areas that you have to have clinical practice in is acute care, outpatient care, skilled nursing, and care in the home. And that's not specific necessarily to, home health. It could be Med B services delivered in the home, so just in the home setting for that.
Nice.
And so across that, when you split up that 1,500 hours, each residency is going to be different on how much time necessarily you spend in each of those respective areas. How we do that at Creighton is through 6-month blocks between 2 different settings. And so you get quite a bit more than 5% in each respective area for our clinical practice. Additionally, requirements for residency program do have 300 hours carved out for didactics or coursework. And so we track that across our residency program. There is not a laid out curriculum, though, by any means. So each residency program kind of determines how they're going to do that. Some programs you may find that they have certain MedBridge courses that they promote, or it could be some of your MMOA material that they promote through their residency program for them to complete. I will say here at Creighton, since we have quite a few residency programs, we have 6 collectively, as well as OT fellowships within our school too. We have what we call a common core curriculum that has coursework that is impactful across our residency and fellowship programs. For example, we talk about like communication strategies. We talk about obesity would be an example in there. Clinical reasoning are basic topics. But then we have specific geriatric topics that could be, for example, neuromuscular changes with aging that are specific to our Geri fellows, residents, and sometimes the neuro resident hops in if they're applicable, like for that particular topic. Awesome. Additionally, there is a scholarship requirement with residency education, but what that looks like kind of depends. So that can be a poster presentation. It could be a platform, at CSM, for example. It could be that you write up a case report, but some type of scholarly product comes out of that. And not a requirement, but what we do have in our program at Creighton is we do allow our residents the opportunity to teach. So they get to be in the classroom, they get to teach in labs, teach some lectures related to aging and older adults. So they get even that feedback. So if they want to pursue academics, after they're done with residency, they have some experience under their belt that can really make them competitive for an academic position.
Yeah, that's awesome. And I will say it, so it doesn't come out of your mouth, but not all geriatric residencies are created equal. And we're not going to name names or anything, but I think people do need to be aware that the quality of the experience can vary, right? Just like in different DPT programs, that some are going to have a little more, they'll follow through with some of the promises more than others. And Dustin,
to that end, I want to point out too, not all residency programs are affiliated or run through academic institutes. Some of them are just out of a clinic too. And so in order to find like that didactic or coursework, that may be a little bit more challenging as opposed to, our program we're within Creighton. And so we have faculty that teach in all the respective areas that contribute to it. So yes, they're definitely not all created equal.
Yeah. And that's like, for me, in my experience, not in a residency, but discussing with other clinicians, like some of those settings, it can be more conducive to, I wouldn't say like horror stories, but things that you would hear about, the amount of extra, clinical hours without maybe some of the didactic or some of the support from that angle, or mentorship, for example, almost like you're just getting more and more reps and reps and reps, but not necessarily as much of an infrastructure to support the mentorship and the didactic side of things.
Yes, and I forgot that. So let me circle back to the requirement for accreditation for mentorship. So sorry for that oversight, but they do have the requirement of 150 hours over the residency program, where 100 of those 150 hours have to be mentorship that you receive as a resident or you are treating the patient. And then 50 of those hours are when your mentor's treating the patient and you're getting mentorship and seeing them in action. So, and that's really the most critical component of the residency program is that mentorship and what people go to residency for and what they say was the most impactful for them following residency.
Yeah. And I think everyone here can appreciate that and admire that. And I think there's a lot of folks that may watch or listen to this where they have, whether it was a residency program or a job. I mean, having so much with first jobs of what is promised, right? This happened to me. Like, all right, you're going to see this many folks and we're going to have, 3 hours a week carved out for a case study, review and reading different research. And then you actually show up and then, you've got 7 evals on your schedule day one, right? And where'd those 3 hours go, So yeah, it's when that happens, the mentorship, that amount too, like over that year, like that can be such a potent thing.
Yeah. Can I expand on that just even a little?
Yeah, for sure.
So just because I'm very familiar with the paperwork and the accreditation that goes in for residency program for mentors. With the mentors, you do have to have them with expertise in each of the respective practice areas to provide mentorship. And so kind of a difference, between if you were to go into like clinical practice straight out of school or just for your career to pursue that specialization as compared to residency, we actually have to go through and like prove that our mentors have the specialization training and the experience in addition to be able to provide mentorship. Do they have, it's a minimum of 3 years practicing in each setting, or you can have a specialization or, hopefully both. That would be awesome for our mentors, for them to provide. And so at Creighton here, we have like 2 mentors in our skilled nursing setting. We have 1 in outpatient, 1 in acute care, and then 2 in our home health setting. So you get then at our program, like 6 mentors across that year that hopefully you keep in touch with 2 that are then mentors in the future as well.
Yeah. And that's so potent. I mean, you think of the infrastructure you all have to be able to support that and provide such a diverse experience. And especially in geriatrics, like that is so valuable, right? To understand what many of these folks have been through, to understand, what they experience in the skilled nursing facility right before you may have seen them in home health or outpatient, like just to get exposure to that continuum of care. And mentorship in those different areas is awesome. Are there many programs that are not, certified, that have not met those stringent requirements?
I would say that, so to get accredited, so most programs, they either are accredited or they're working on it. And most of them, it just takes a year, as if everything goes according to plan. So the plan is that you do get accredited, so that way you can be listed on the website so people can find you as a residency program. And if you don't meet the accreditation, if you're just running shop and you say you're a residency program, it doesn't count then to really sit for the exam then, because it has to be an accredited program to give you that qualification to sit for the specialization exam.
Yeah. Awesome. So there's a lot of pros. I want to discuss, I think for some of the very obvious ones for me, is for those that may have interest in research, in academia, in teaching others. That seems like the best route to give you the highest odds to end up in that position. Would you have anything to add to that? And then what other pros or situations that students may find themselves in do you think make it a really good option for folks to go this route?
Yeah, so I have a kind of a list here that is kind of just listing the differences between residency versus if you're just a full-time clinician. And I do want to make sure that we mention residency is not just for folks that are new grads. You can do a residency anytime. You can be out practicing for a few years and come back and be out practicing for over a decade and go to a residency. Some of the reasons, though, that I would say people don't consider residency sometimes is because of the money. So when you're a resident, depending on the program, you may have to pay tuition. Our program, we don't have you pay tuition, but your salary that you get as a resident can sometimes be a deterrent because it's not a full salary. It's really based off how much of your time is in the clinic. So some residency programs will do more than that 1,500 hours that I mentioned, and often that's reflected in the salary then that you get as a resident. And all of that's posted with each specific residency program. They have what they call the financial fact sheet. So you can see, what those tuition dollars are, as well as what your salary would be before you even would consider applying. So all that information's...
Are you able to throw some ballpark numbers out? Like, obviously not holding you to anything, but like just in general, is there like a typical range?
Yeah. So usually like the national average is right around like 52 to 55,000. And usually what you think about it as is, about like 75% usually of what a PT would make in your area. So yes, there is that kind of salary cut there that I want to mention. As far as we kind of already mentioned the difference between mentorship, you may go into a position saying that there's, time carved out for mentorship, but does it actually happen? Is it someone that has the expertise that you need? That can be a difference and maybe a reason to go into a residency program. One thing that I feel like for myself, as well as some of the residents that have gone through our program, that they've said that I think is really cool, is that they say in PT school, they learned, and I agree with this, I would say this as well, you learn what to do, but residency tells you how to think, tells you how to really leverage that education and know when to apply it in certain situations, and really fast tracks that clinical reasoning process. And even some of our residents have said, I feel like my clinical reasoning is even beyond some folks that have been out 10 years, just because I was able to have this supercharged experience where I had all of this feedback within 1 year to really escalate that. The other thing, so with meeting the requirements and feeling prepared for that exam, and I know we didn't talk about the hours if you were to go the other option. So in order to qualify to sit for the specialization exam, you need to turn in 2,000 hours of practice over a 10-year period, and a quarter of those need to happen in the previous or the 3 years just prior to you wanting to sit to that exam, so 500 hours. So
and
just
then it's good for, I believe, 10 years.
Yes, for 10 years. And then you're kind of, as you mentioned, on your own to how to craft your studying for that specialization exam. So residency gives you that option. It's already crafted and developed for you to guide you to hopefully be successful at passing that exam. And I will do a small stats drop here. So on average, over the last 10, 15 years, for those that have undergone residency training in any specialization area, their chances of passing the specialization exam is about 10 to 15% higher if they went through a residency. And the 2023 stats for those that specifically underwent a geriatric physical therapy residency, 100% of them in 2023 passed the exam, while only 88% of those that studied on their own were able to pass it that first time. So we know that, what we're crafting, hopefully in residency, seems to be working to help you be successful. Obviously, the other part, as we were talking about the hours, the residency is the fast track to give you the credentials to sit for that specialization exam. You get it in 1 year, as opposed to accruing these hours and going through your own studying and curriculum. That may take you longer than an hour. So you may be able to, achieve that a lot faster through a residency program. I do want to make a special note about student loans as well. So those can be deferred when you're in a residency program, as compared to if you go straight out into clinical practice, you need to start paying those right away. And lastly, a plug for the APTA. I'm not sure how much you promote membership or resources at all, Dustin, but you do get a discounted membership if you're in a residency program through their post-professional membership discounts, as opposed to if you just go straight into clinical practice. They do have some ways of reducing it over time. but the discount with residency is a bit better. That can be helpful for, because that membership, I've felt the effects of having to pay the full membership now, and it ended up there at a high number quick.
Yep. For sure.
So that's kind of like my list for the side-by-side comparison.
Yeah. And I think, so the fast track, I think, is super valuable, right? I mean, just to have that compressed learning in a very short period of time, whether it's right after you graduate or later on, I mean, that's really valuable. And what it can set you up for, especially in the realm of academia and research, like that is, I mean, would you call that an essential step at this point to make it into a teaching role in most institutions? Or at least a board-certified specialist in a particular area?
Yeah, so to be at a CAPD accredited program as like a full-time faculty member, you do need to have either a specialization or terminal degree. And to get experience, to be competitive for a faculty position, you don't necessarily have to do a residency, but we definitely strongly consider folks that do have experience in the classroom. And you can be, a teacher's assistant, come in and do some guest lectures to do some of that experience. Often those are paid opportunities. But, the feedback that you get, like with our residency program, and like I said, not every residency program gives you the teaching opportunities. It just depends on the program. But yes, that can be extremely helpful if individuals are considering that academic route.
Yeah. And so some things to consider, and this is what, I was thinking about when, I was coming out of school and trying to figure out, what path, I was going to take. Obviously the financial considerations, right? Like we got to factor that in. Is that something that you're able and willing to do compared to, what you could potentially make with the first job, for example? Location is another one, right? Like, are you close? Are you willing to relocate? That's why, like a place like Creighton, if you are going to, PT school, like right down the street, basically, and it's very natural and very conducive. And so folks need to take that into consideration. But I mean, there's lots of pros.
Go ahead.
What? Sorry, go ahead.
Often that's the barrier, is just the location part of it, because residencies are not a remote option. You have to physically be there to complete them. And, if you have a spouse or family where you're not able to relocate, that's often that initial barrier that is the reason why people pursue it or don't.
Yeah. And especially in our world of geriatric residencies, I don't know the numbers, but in terms of like, orthopedic residencies, it seems like there's one around every corner. Jared, there's not as many. So yeah, just being aware of that. Awesome. So let's shift gears, and I'll probably just share more of kind of my perspective with the other two. We'll speak to if you were to just sit for your GCS and some of the pros and cons of that. When you do not go to a residency. And so that was my route. And I spent a lot of my time in home health. And I was definitely in a position where mentorship and a lot of things were promised that didn't necessarily happen. And so anyone that has jumped into home health has felt this, where they felt like they were on an island, right? What in the world do I do in these situations? And I think there's some benefits to that. Like you definitely learn how to solve problems. You become kind of a jack of all trades in a way, kind of a MacGyver-esque, therapist out in the world, but you don't have that mentorship, right? Like you may develop some bad habits or some poor, critical thinking skills. Like there's a lot of opportunity to kind of go one of two directions. And for me, I felt that tension. And so with, considering cost, phase of life, not necessarily near residency, I decided to sit for that GCS. And I prepped with good old Guccione, Avers, the textbook, did some different courses. And what was very helpful with taking that exam was to have a greater medical understanding of what my folks are going through, to really level up screening and examination, and just to be able to develop a clear plan of care of what is most important for this person to really move the needle in terms of their quality of life and different outcome measures. The emphasis on outcome measures I really appreciated. Pharmacology as well. Where I believe the GCS alone is lacking is, what do you do after that? The intervention piece. When you're not surrounded by residency, when mentors that are able to show you, all right, here's what this looks like, to do this with individuals. If you're just out there alone and you take the test, the practical implications of what your sessions will look like afterwards, at least for me, it didn't seem to impact tremendously, or I did not have a great understanding of therapeutic exercise prescription and then progression, how to handle flare-ups, just some of the things that you would run into in a regular practice. So I found it beneficial, but I really felt it lacking from, all right, what do we do after that first visit and the examination? And I definitely understand how, in the context of a residency, that test, you may not feel that because you've spent time with folks, you've seen it, you spend so many hours with individuals in different settings, seeing how these things are implemented. But I've definitely felt that. Would you have anything to add to that in terms of, just sitting for the GCS, separate from, completing a residency?
Yeah. I would just say that what the GCS means, if you just sit for it, it says that you have the knowledge, you have passed the test, but all of the critical components that we also assess in residency, where we have live patient exams that people have to pass, we're really assessing, are you putting it into action? Are you practicing these higher level skills? And so you get that additional feedback and that development as well.
Yeah. Yeah. And another, I wouldn't say critique, but just I think reality in our profession is, there's going to be some places of work that value that certification, that may even compensate a little more for that certification. There's a lot of folks that don't. A lot of places that are, unfortunately, do you have a license, right? Can we bill? Are you able to bill Medicare, for example? And so the weight, from the workplace standpoint, the weight of that certification, depending on where you're at, it may be valued and it may not. And I definitely want to acknowledge the places where it is valued, to where you may get a bump in your pay, you may have more opportunities in your particular area, but that is not the case in every single place where you're going to practice as a physical therapist. So just being aware of that for folks that think that they're going to get this GCS behind their name and all of their problems are going to be fixed and they're going to, get this huge raise and so on and so forth. It can happen like that, but sometimes it doesn't.
Well, and I would say if you're interviewing for a job and you have that GCS, you may need to explain what that means to your employer more. They probably may not be aware of it if they aren't familiar with specializations in any area. And just telling them more about that and what that means and how that is an advantage to your employer. So oftentimes this means maybe you're able to deliver more effective plan of care where maybe it's shorter or they're able to get better faster. Maybe you're being more productive, having those kind of buzzwords ready so that you can describe and show why you're going to be, a better candidate than someone that may seem equal to you that doesn't have the GCS.
Yeah. Yeah, and that's a really good point, because I had to do that in the context of home health. Of many folks in a leadership position were mainly nursing, and they weren't even aware of a GCS. To say, hey, I got this certification, and I had to inform them, which they appreciated, right? But yeah, so that I think that's understanding that for folks is pretty important. So that was my route. And then for me, that's what really motivated me to get into the continuing education space, is the pain that I felt from going through that experience, feeling that tension, especially in the context of home health, not having the mentorship or the support that was promised, how could we create very practical avenues for folks to learn, to be supported, to where their practice is different come Monday. So they know how to prescribe some of these things, to implement these plans of cares, but then also to be able to handle all the bumps that are going to happen, the flare-ups, the issues. Nothing ever goes as planned, right? And so to be able to allow folks to use the information come Monday, for me, that was just such a big driver. And I'm not saying it's we're perfect by any means, but I definitely feel having that front of mind, I've really kind of enjoyed that, knowing that I view that as just another option and kind of a compliment to folks that may not be able to go that residency route for whatever reason that we've outlined before. But what makes me excited is that there are options that we are able to do a residency or sit for a GCS or go to some continuing education courses to receive, some specialized training. Because I think the bigger issue is the lack of representation of this demographic in the DPT program, in some DPT programs. That by and large, it's the majority of the folks that we're working with in our profession, all the sports ortho PTs that are learning all of their fun exercises and all their examination techniques. And then they, get out in the real world and, over half of their outpatient caseload is over 65, right? They weren't necessarily prepared for that, depending on what program they went to. And so I really yearn for the day, where what we're teaching isn't necessary. It is so baked into the curriculum of every clinician that it's not anything new per se or different than what they're getting, which I'm not in academia. I haven't experienced the pains of having to meet all the requirements to become an accredited program. So I definitely want to be, sympathetic there, and understanding. But I do think it is an issue when the vast majority of folks are going to be working with older adults, and they're largely, underrepresented in a lot of programs, not all of them, but a good bit.
Yeah. And I think you bring up an important point as something that's being kind of evaluated and investigated further. It's just the overall interest in geriatrics with physical therapists.
Yeah.
And many of them, if they do have an interest in it, it's not, ignited during the PT program. Maybe that's an indication that, we're not delivering that content either in enough quantity or, with enough excitement, because it's easy to take the negative side of things with aging and all the downsides. But really the tremendous impact that we can have as physical therapists is astronomical with older adults and the gains that we can have. And I think doing a better job on the educational side in the clinic on clinical rotations with students to get them excited about this, because I'll say across the residency programs for geriatrics, specifically in the country, most years, not all the seats are even filled in those programs because we just didn't have enough people interested in pursuing that route. And as we said, for a multitude of reasons, but we're not seeing those same trends in, other programs such as ortho and sports and those type of areas. They're still, moving to those locations and doing the residency programs. So I think we can, and with your material, obviously, and your podcast and continuing ed, you're definitely doing that, trying to promote how there's so much growth that we can have and excitement surrounding geriatric PT.
Yeah. We want to make Jerry sexy. That's the goal. I'm trying. It's because I went through it myself, right? I was the classic PT sports, ATC, had my CSCS. I was going down that sports PT route, and then was exposed to this kind of forcefully, exposed to this population that I had always written off, oh, I won't do that. That's super lame. I'm going to be working with the team or the super fun, sports ortho clinic. And then you learn otherwise and learn, how fulfilling it can be to work with these folks. And there's just such huge opportunity for impact. And I think even more so than, maybe working with athletes, for example. I say this all the time, but I just distinctly remember working so hard to squeeze out an extra 1, 2, 3% of improved performance in a different variable, right, with an athlete to just, increase their odds of winning or performing better by, a little bit. And then to take that same effort and apply it to an individual that may be deconditioned, that just came, out of the hospital into their home after having a really, really rough time, and you apply our intervention that we can apply and see tremendous percentages of improvement across several different performance variables in a relatively short period of time, sometimes, a couple weeks. And that, for me, as like a clinician, was addictive, which it's counterintuitive, right? You typically don't think like progress in geriatrics. It's like, man, some of these folks like respond in such a dramatic manner to what we can do. And that, that really got me excited, and still does today. And I just hope, students and clinicians can see that and appreciate it, and just realize like what they can offer this group of folks.
And that impact even can translate to whether they're able to go home, or if they have to go, like how you're making life impacts on them. Can they actually attend their grandkids' game? Because now they can walk the distance from the parking lot to where, they need to go in the building. Like, it's amazing.
It's huge. It's huge. And what's cool too is, kind of getting off topic here a little bit, but I think it's appropriate. But what's really cool too is to see the increased interests from the fitness profession as well. So I'll interact with a ton of fitness professionals, CrossFit coaches, that are really seeing that, man, when, I'm able to maybe work with a physical therapist and understand this person's situation, then apply effective exercise prescription in the context of fitness for those that, it's applicable. They're starting to see the impact that they can have. And I think overall we are seeing kind of a shift in perspective of older adults, and just seeing how valuable we are on that side of things, which has me pretty excited. So, all right, well, Rashelle, thank you. This is a really good conversation. I learned a ton. I hope the listeners and viewers learned a ton as well. If students, if folks or clinicians had questions for you about maybe residency, GCS, that type of stuff, is there an appropriate avenue that they could potentially contact you?
Yeah, you can just look up my faculty profile. My email's on there. Shoot me an email, and I'll be in touch.
All right. And I will link her faculty profile in the description of this podcast. It'll be on the YouTube video as well. So feel free to hit Rashelle up. If y'all have any questions for me, hit me up as well. But I really appreciate this conversation, Rashelle, to just lay out some of the different avenues, the pros, the cons, and hopefully help some folks out to just make a really big decision, in their lives and careers, that hopefully they'll be able to get the most out of it, and be better as a result. So I appreciate you.
Thank you. Fun conversation today.
Yeah.